Top Med Talk.
Hello and welcome to Top Med Talk. I'm your host, Desiree Chappell, and we are covering the COVID-19 crisis from the front lines. We have been chatting with providers from all over the world over the past several weeks, and they've been telling us about their experiences treating, taking care of, and managing COVID patients. As usual, I am joined by our editor-in-chief, our leader, but also our COVID patient, Monty Mythen. Hello, Monty.
Hey, Desiree. Good afternoon. Good morning to you. Yeah, I think I probably might have to shed the patient badge now.
Yeah, is it over? That's what I was just going to ask you.
It is day 14 now. So tonight, 2 weeks ago, was the first time that I got proper sick. So maybe that would count as tomorrow because it was in the middle of the night. As I've been saying, I'm very, very lucky that although I've had a sort of double bump, as you might put it, and I have not bounced back as hard as I had hoped. My recovery has been consistent with my more middle-aged, the peri-60-year-old colleagues that I have. So they've all sort of reported a bit of more grumbling recovery than sort of classical hard bounce.
Yeah, Monty, you said you were having like you were just your stamina, everything was kind of down. You've been getting out to work out just a little bit?
I started walking. I've been balancing the messaging about, which I don't usually adhere to when it comes to sort of being unwell, is this idea that you should look after yourself and be careful with regards to overworking your lungs and overworking your heart. I'm usually a bit kind of, work through it. But this as being more of a virus and more flu-like, I think it's much more serious messaging from that perspective. Mm-hmm. So I have been taking a relatively slow and cautious reapproach to my rehabilitation. So increasing my gentle exercise program per day for the last few days, and I think that's going pretty well.
Well, good. Returning back to your old sassy self.
Definitely that. Some of my tweets definitely imply the fact
that you're feeling better.
And some of the stuff I haven't shared that I've been discussing with my colleagues. We have a very lively WhatsApp groups at work, and I definitely got a bit punchier earlier on today.
Yeah, I was going to say, I could tell a difference from last week to this week. For sure. But I'm glad you're back in full form.
I think we're staying pretty well connected as well. I mean, I'm talking to colleagues every day of the week. We have virtual ward rounds, two main ones each day of the week, and sometimes they're broader. We have broader network catch-up calls. And for example, I was able to get Professor Hugh Montgomery, who is a colleague of mine at UCL that we interviewed before, one of the national leaders from the Intensive Care Society. I managed to grab him for about 15 minutes for a personal update earlier today. He's been really, really working hard at the Whittington Hospital in North London, where I think they've been really right up against it, as London is. I mean, London is pretty much as anticipated.
What did Hugh have to say?
He says it's been really tough. Yeah. It has been described elsewhere. It is just keeps coming and keeps coming. And it's unfamiliar territory, nursing ratios that we've never been used to before, people getting fatigued. I think they're feeling protected from the point of view of having the equipment they need, etc. Have to be careful about naming trusts and talking about individual experiences here, but I think it talks very, very positively about the support from the National Health Service, the support from him employer. It's just a lot of sick people. And as he said, I was sharing personal experiences as someone who's had a mild dose of it, if you see what I mean, and what he's seeing in patients. It's a complicated and nasty disease. Yeah. And it's not like a lot of sepsis we've seen in the past, and it's not like a lot of so-called ARDS, adult respiratory distress syndrome, we've seen in the past. It's different, like a lot of so-called ARDS, adult respiratory distress syndrome, we've seen in the past. It's different.
Really, I do want to say that, we have been talking about when we were first initially dealing with this and some of the first reports coming out of China and Italy that it really was like ARDS. But I think that's been one of the things that's been changing over the last several weeks is how this is actually presenting.
Well, I was listening to the European Society of Anesthesia webinar that I talked about and Professor Pelosi's lecture, which is a few weeks ago now, as I remember from that, and I have to re-listen to it, is them saying that it is relatively easy to ventilate lungs in the first process, so it's not the ventilation that's the challenge. That as it progressed, I think I remember him saying that they moved to being less PEEP rather than the high titrated PEEP that you often see in the ARDS protocols. And it's more of a perfusion problem in the lungs, not a ventilation problem in the lungs. So for the experts listening, we all know about VQ matching, the matching between the ventilation and the blood supply to the lungs. And usually we're dealing with more of a V problem. Yeah. So it's blowing the balloon up is the challenge.
Because with ARDS, so just to take it back, exactly. It's the ARDS, the stiff, like the stiff lungs, so you can't get it.
Yes, stiff lungs, often because there's been a proteinaceous goo that has leaked out from between the blood vessels and the lung itself, which is a very fine gossamer-like of structure, very, very, if you cut it open, very like sponge-like structure. Then in classical ARDS, protein leaks in there and it becomes very stiff and hard to ventilate.
And the surfactants and all.
Exactly. Here they describe a floppy lung is what's quite often described, and PEEP being positive expiratory pressure at higher levels being less helpful because it just over distends parts of the lungs where ventilation isn't the problem. And the problem seems to be much more on the perfusion side, which we refer to as Q in the VQ, ventilation perfusion matching. Yeah. Or more typically it should be Q dot, as I'm often corrected about. But when we talk about VQ matching, and I think the biology behind that's been relatively well described right from the beginning of this journey, but increasingly people understanding that it's a problem with the small blood vessels and an unusual form of clotting in the small blood vessels.
Yeah, we were talking about that, and it's kind of that microvascular. Can you you explained this to me earlier. I think you did a fantastic job of kind of walking me through what that looks like.
As they describe it, and there's lots of different markers that can be measured in the bloodstream that suggest this is going on, and now there's other signals coming through about there being thrombosis problems in small vessels. I mean, those of us in the medical field will all have learnt in our clinical training about DIC, for example, disseminated intravascular coagulopathy, which you get, depending on what causes it, you get blood clots forming in the very small vessels, the capillaries, at the same time as you get bleeding in the big vessels because you've consumed all the clotting factors. Yeah. Now, no one's saying this is DIC, but on that whole spectrum of diseases that manifest themselves as clotting of the small vessels, it seems to be a small vessel clotting problem. So part of it, as all this develops, and we're in no way suggesting any forms of treatments here, but this is a lot of the chat in both the mainstream medical literature, the scientific literature, and the soft science literature, is discussions about anticoagulation and different parts of the coagulation pathways that could be manipulated in different ways to try and improve outcome. Now, I sent you a link, and it's on Twitter. The International Society of Thrombosis and Hemostasis, ISTH, we'll put the link in, is running a webinar later in the week by two global leaders in this space. It's complicated stuff, but I'm certainly going to try and listen in because I want to understand more about it.
Yeah, it's Professor Beverly Hunt, OBE, and Marcel Levy or Levi.
Marcel Levy. He's actually our chief executive officer. We're very privileged at University College London Hospitals to have a clinician scientist, so somebody who's a frontline doctor, as well as being a world-leading scientist. And Professor Beverly Hunt, Bev Hunt, is from the south of River St. Thomas's Hospital is where she comes from. So again, another global leader in this complicated field of thrombosis and hemostasis. So the International Society, if you're in this field, is extremely well known. And as I said, I'm certainly going to listen into that.
One of the things that we were talking about, and I brought it up, that after you've had COVID, now will you be donating blood or plasma, anything for possible treatment of patients? Are they doing those types of studies there?
Literally the last hour or so, I had a call from one of my colleagues who is doing a science overlaps with epidemiology study of people at various different stages of the disease. So as part of that, they're looking for people who are recovering from COVID-19. You've had a positive test. So I agreed to, if they still want me to, depending on where I am in their numbers matching, I'll give some blood to contribute to that study. I think it's slightly different to me going to donate blood, which I have not been approached about, or maybe not been approached about yet, which is this idea that you can donate blood and then the plasma from people who have successfully recovered from COVID-19 should have high amounts of antibody in their blood. And not only that will that accelerate the science of understanding the antibodies, but there's also potential to do trials to see if you give the so-called hyperimmune plasma extract, sometimes coming out of so-called FFP or fresh frozen plasma, that you might be able to, in trials, to give that to people to see if it increases their chance of surviving. And that sort of thing has been done I would say, loads of time in the past. That's not true. If you look up on PubMed, if you go to the US government medical search site and you look up hyperimmune plasma, I can remember back even into the 80s when there was quite a lot of endotoxin research going on. You'll find papers there in the New England Journal of Medicine about people being vaccinated with a modified version of endotoxin and therefore getting high levels of antibody in their plasma, and then randomizing patients with sepsis, with gram-negative sepsis, to receiving this hyperimmune fresh frozen plasma or the non-hyperimmune. And in the early studies, there'd been quite a big difference in mortality. And indeed, myself and my colleagues in London were involved in decades later in a trial of something similar using donors from the London blood banks to give people hyperimmune fresh frozen plasma.
Yeah, surgical patients, the cardiac patients. Tell me about that.
You'll find it if you look up Hamilton-Davis as a hook. You'll find some of the early work by Colin done on endotoxin antibodies and hyperimmune fresh frozen plasma to that, and some of the early pilot work done.
And so
this type of thing's been done before.
Yeah, and it's the assumption that it's working for bacterial infections, but it can work for the viral infections as well.
I'm imagining if we can, which is every reason one would think, mount an antibody response, I should be teeming with COVID-19 antibodies at the moment. Therefore, if you extract my plasma, there's a reasonable chance that within that whole soup, without even knowing it's specifically the antibody, that may be of benefits to patients. Now, this is very, very complicated research area because you'd be giving a whole soup of different elements, different proteins, different antibodies, different antigens even that might be up in my own plasma. And you wouldn't know exactly what you were giving to patients at the time. However, if you were going to be giving those patients some donated fresh frozen plasma, which you may well be doing that in the context of critical illness, then like the previous studies that we were involved with, you could select out that rather than just getting the general pool of fresh frozen plasma, you could give it specifically from hyperimmune plasma pool and therefore see if that made a difference to subsequent outcome. All these types of trials can be done pretty quickly at the moment because we've got a large number of people with a common disease process.
Yeah. It sounds like there are people all over the world actually that are trying this particular treatment.
Yeah, I think the really important thing is to try and do these things in not based on anecdotes and not based on, I heard this on the Twitter sphere or whatever it was, in rapidly organized and appropriately designed clinical trials where we have so-called equipoise. So we have an equipoise is strength, where we have uncertainty that we are prepared to accept either the controlled randomized controlled trial or the natural experiment, but to make sure that we capture the information such that we can learn from it. And many of the trials are now being organized to have a so-called adaptive trial design. So if we have two different modes of ventilation, for example, if there is a winner that starts to show, then we can switch into the winning team as quickly as possible.
Oh, okay.
But we have to test the different versions of it because you can have your bias can come to bear and you can believe, and these beliefs are very, very strong. You can believe that one therapy is superior to another therapy. And without having data to back it up, they're dangerous beliefs.
Yeah.
We've got to be prepared for our biases to be challenged. And that's what makes us clinicians and scientists.
Are you getting strong signals from colleagues that they are ready to do those types of things? Or are you still hearing a lot of people that are pretty much digging their heels in and sticking with what they believe?
I think in this day and age, there's relatively few people digging their heels in because if we go back 15 years ago, people were struggling in some places with equipoise because they've been brought up to believe that certain behavior patterns in intensive care were truisms. In other words, they had a belief, for example, that a particular way of feeding somebody or a route to feed somebody or a level of blood sugar was an absolute truth. Yeah. Then when the large trials have been done, the big signal from the very big trials is very little has stood up to scrutiny. So most of our totems, our gods of critical care, have turned out not to be true totems or true gods. So I think the generations that have followed have a lot more of this equipoise. They have a lot more of, we must be prepared to ask the question because we're as likely to be right as we are to be wrong.
Yeah.
So we've got to seek the truth in it.
And Monty, this is a question for our listeners. Can you explain what equipoise is?
Equipoise is a willingness, particularly from the practitioners involved, but we then have to ask our patients to consent to that. So the willingness to accept the fact that treatment A may be superior or inferior or no different to treatment B. Lack of equipoise is when you say, I am so deeply, deeply believe that this particular treatment is in my patient's best interest. I will not accept them being randomized into a trial. And lack of, so you can have individual lack of equipoise. So in other words, I will never let a patient that I look after be randomized into this trial. Or you can have lack of group equipoise. Gotcha. Now, that was much more common before we got involved in doing a whole slew now of very large randomized controlled trials in critical care. Because I think a lot of people turned around at the end of it and said, I cannot believe that the answer to that question is either no difference or contrary to my lifelong belief that this was in the patient's best interest.
Yeah, that probably helped the cause. Okay, Monty. So speaking of trials, there's a post that you, again, being a little cheeky on Twitter these days.
What have I done now?
No. You were talking about, and this goes back to the conversation we were having about the coagulopathies and all those issues. And you said, I just asked a well-known UK prof of critical care on the front lines the same question about APC, which is activated protein C. And could you do a trial quickly under these circumstances? Equipoise is a strength. So tell me about what prompted that.
Some of the listeners will remember that activated protein C got through phase 3 and became approved as one of these treatments for severely unwell, critically ill patient with a suggestion that there was a survival advantage. Like all of these very novel treatments, because there's a huge amount of money that goes into developing them and in particularly testing them, it was on an individual patient basis a very expensive drug, although many people thought it was a very high value drug. I have equipoise about activated protein C. Subsequent follow-up trials resulted in a conclusion that it probably wasn't as good as the earlier trials had suggested, and it was actually withdrawn as a drug. Now, the way that it worked, the specific mechanisms by which it worked, might be highly relevant to the biology and pathophysiology of the way this current virus manifests itself. So it might have been an opportunity to specifically explore, supported by some of the biomarkers, the measurements in blood that was allowed us to target the treatment. So it's one of those things where the people who still want to know the answer to the question because they got the impression that it did work in a subset of people is whether they could find some of it, dust it off, and get permission, if deemed to be appropriate, to rapidly do a randomized controlled trial to see if it had anything to offer under these circumstances. That's what that discussion's all about. I have no skin in that game. I have no bias one way or another. I have no strong beliefs or disbeliefs in it as a product. But it is a product that seems to be biologically much closer to what we're discussing as one of the fundamental problems here.
Yeah, I think it's just another great example of what we've been talking about with equipoise. And, we're not looking for the unicorn necessarily, but we are trying to use what we've learned in the past and apply it to this particular.
I have no idea where it is at the moment. I have no idea, but it got all the way through phase 3 and was approved by the European regulatory agencies and the FDA. Yeah. So a lot of the potential safety concerns that are there that may have been flushed out, under these circumstances, a lot of the really hard work has been done to make it suitable for seeing if it would be possibly tested in this situation. Now, I'm way off piste from me. I used to know a little bit about this sort of stuff. Part of my 50% of my thesis is all about this sort of area, but I know a little bit more about Renaissance art than I do now about thrombosis and hemostasis. And that ain't much.
Well, I think it doesn't hurt to have these conversations.
But we must just not give people false hope and say, can I have some of that hydroxyquinolone type of stuff?
Well, Monty, you've reported on the UK. I just wanted to take a moment to say how proud I am of our state leadership. Usually in Kentucky, when we say we're in the bottom 3 of anything, it's usually a negative: education, health, you name it. We are not usually at the top of the list. But this particular instance, we are at the bottom of the list for COVID patient ramp up of cases. And we've had very, very strong leadership within the state from our governor, Andy Beshear, who's made national media attention because of his leadership.
You seem to get our lid on it very quickly.
He did. So we had he called school off very quickly. We had social.
But even with us chatting, you shut your schools way ahead of us in 2 London, weeks. And you were a long way behind the curve as well.
Yeah, so we stopped it. He did social distancing. And I have to tell you, wherever you are in the world, if you can look up Andy Beshear, some of his press briefings, I would put them next to Governor Cuomo in New York. He's doing an excellent job. And for the people of the state, he is doing the top 10 things that we need to do as citizens because we ourselves, we can prevent this from becoming a disaster as it happened in other places around the U.S. and around the world. And so he goes over the top 10 every single time. He goes over, where we are in the state, what's happening. And we hear from our medical director in the state. So it's absolutely fantastic. And I have to say that I'm very, very proud of our governor and the leadership that he's shown during this crisis, because it could be a lot worse. Kentucky has been always known for being kind of the last ones to follow suit and follow national recommendations. So I think that we've done a cool thing, and that means other places can as well.
And a spell check for Beshear?
Beshear. Andy Beshear, governor of Kentucky. And those press briefings are great if you want to share with family members, because they work for anywhere, no matter where you are in the world. They're fantastic.
It's less common to hear people speak out very positively about the strength of their leadership under these circumstances. But there are a few. Our Queen did a great job as well yesterday, I think, from the point of view of speaking to people's hearts and minds.
She did. It was so very reassuring, and really that's her job, isn't it?
Yeah.
So I think it was good to hear from her. And anytime, I think we hear so much negativity coming out from media or wherever it's coming from, and negativity in a way of we're really kind of way behind on where we need to be. But I think it's great to hear, 1, positivity, and 2, straight talk.
Actually, on that point, I mean, I've included on Top Med Talk, I've said some fairly negative things under these difficult circumstances about the relentless political spinning and exaggerating of certain different pieces of messaging. And I said that, last night on one of the programs, one of the guests there called out and said, why don't you switch all this around and, promise less and deliver more? Yes. For the first time yesterday on political TV, I heard some of our leaders just seem to completely speak the untainted, unspun truth as we see it. There's a lot of uncertainty. There's a lot of we don't knows. There's a lot of, and to me, it came over as just so much better. Yeah. Just tell me, you don't have to, if the real answer is 1,000, don't call it 4,000.
Right.
It's okay to say, I think we've got about 1,000, and it really is about 1,000. Even better, it'll turn out to be 1,200. Yeah.
And if the real answer is 4,000, tell us 4,000.
It's okay. Yeah. We're going to find out.
Yes.
And it's
being published somewhere.
I think we might have got a lid on all of that.
Yeah.
So I think we may have a few mixed in with all of this getting a little bit under control, we hope, fingers crossed, even though there's a lot of lives still being sadly lost. We might have 4 to 6 weeks of untainted honesty.
Yeah, which would be, I think, work well for us, especially those who are on the front lines and who have to hear this and know that something is going on, but it's not being reported accurately. So I think that's going to help those people to do their job better and their head at least be in a better place.
I mean, no one's saying this is an easy time to lead. This is with great, enormous respect to all of you, but it's all right just to tell us the way it is. We're okay with the truth.
And I think that goes for, all of us the medical community on social media as well. I think we need to follow those same kind of parameters. I think that we do a much better job usually, but it's interesting. So thanks for listening. I hope everyone stays safe out there. Monty, I know you're going in tomorrow.
I am. That's the aim. I want to be in early to see my colleagues. I'm going to sort of remember how to don safely, even though I may not need to now, but I think the sensible thing to do is to continue to maxi don and doff correctly and get all those things right.
Yeah.
If anyone, we're getting some great messages come through. We've got some great talks lined up for this week from some areas we haven't spoken to yet. If anyone else wants to share some stories, we'd love to hear from almost anyone.
Yes.
We're going to do some obstetrics this week, aren't we?
Cardiac.
We're going to do some cardiothoracics.
Yeah.
The whole medical world's still going on in parallel.
Yeah.
So all that as well. Yeah. So please do contact us. We'd love to hear from you.
It's contact@topmedtalk.com, contact@topmedtalk.com. Or if you find Monty or I or Top Med Talk on social media, don't be afraid to reach out via that route either. So I hope that you are staying well, and we will catch you again, hopefully tomorrow.
Top Med Talk. Top Med Talk is proud to thank its sponsors, specifically Edwards Life Sciences, for their generous support through this global crisis.